Hello, my dear students. Today we are going to discuss anatomic and physiological peculiarities, methods of objective and additive diagnostics of upper parts of the digestive system and intestines, in children, of course. So we will be working according to the same scheme we are usually working when we are discussing this propedeutic material. And as we used to do it traditionally, we start with anatomic and physiological peculiarities of the highest of the first organ in the gut in general, that is oral cavity. So what are anatomic and physiological peculiarities of oral cavity? First of all, it has relatively small sizes. Tender and thin mucous membrane of oral cavity is rich in blood vessels. Larynx entrance lie high over lower and posterior margin of a soft palate. Immaturity of pairs salivary glands is present, so that's why during first months of the child's life the oral cavity mucous membrane is relatively dry and more fragile by that. And that is why, therefore, during first months of child's life, there is xerostomia, which is more probable to develop than later on when there is already increasing of the activity of the salivary glands. Also, there is low enzymatic activity of saliva, especially amylases produce significantly lesser in comparison with the elder children, and low bactericidal quality of saliva, especially due to the decreased quantity or decreased production of lysosine, very important factor of the local immunological protection. So, summarizing all these things, we may say that due to these anatomic and physiological peculiarities, the mucous membrane of the oral cavity is more fragile, and that is why different inflammatory processes, not just because it is fragile, not because it's more dry, but also due to the decreased local immunological response, how we have mentioned that there is more easy development of inflammatory processes in the oral cavity, and they may be of different types. Stomatitis. Stomatitis is in general term which describes inflammation inside the oral cavity, independently on which part exactly is involved into this inflammatory process. The second one is glossitis, inflammation on the tongue. Cheilitis, usually when we are talking about cheilitis, we mean inflammation in the corner of the mouths or the margins of the mouths as well. And xerostomia, that's what we have already mentioned, that is extreme dryness of the mucous membrane of the oral cavity. That is inflammation in the corners of the mouth, and that is called angular stomatitis or cheilitis. That is also a kind of cheilitis. That is stomatitis with the involvement of the tongue, and that's why it is called glossitis. That is ephthostomatitis. Ephthostomatitis is inflammation of the oral cavity mucous membrane with formation of very typical, very specific round-shaped whitish, because they are covered with fibrin. Small defect lesions. They are so typical and always looking the same that it's very difficult to misdiagnose them. They are very easily to be recognized and diagnosed. If we talk about anatomic and physiological peculiarities of the esophagus, we may admit that esophagus upper boundary lies higher in infants. Its mucous membrane is thin, tender, lack in elastic tissue and muscular layer. Immaturity of glands is present here, and also physiological insufficiency of esophagus lower sphincter is present. So by that we will be able to understand why inflammation inside the esophagus may occur and why it has low peristalsis. Low peristalsis may be explained exactly by lacking in elastic tissue and muscular layer. Also, due to physiological insufficiency of esophagus lower sphincter, which makes it more relaxed, more flabby, more lazy, it's easier relatively coming back of the swallowed food, air, from the stomach to the lower esophagus and even in upper parts, and that is why regurgitation is so widely spread in early age children. And if we are talking about symptoms and syndromes which are related to esophageal dysfunctions, we may say that it's of course pain syndrome, and the basic symptom here is odynophagia, which means painful swallowing. And second syndrome, that's dyspeptic syndrome, which is characterized by the following symptoms like dysphagia, regurgitation, rumination, and eructation. The term dysphagia means problematic or difficult swallowing, and in majority of cases it's considered to be a red flag sign. What is a red flag sign? There are various different gastroenterological red flag signs. These are those symptoms which testify that there is some serious problem present in the organism, and that the doctor should include all possible methods of instrumental and laboratory diagnostics in order to find out which organ is affected, where we have organic pathology. So dysphagia is one of red flag signs, and actually that is one of indications for carrying out of upper endoscopy. If the child has dysphagia, basically you should be ready to identify either the reason is localized on the level of oropharynx, either it is localized on the level of esophagus, its body, or lower esophageal sphincter. That is needed because numerous problems, numerous pathologies may lead in the development of dysphagia. For example, if we are talking about the reasons localized on the level of oropharynx, we may say that they may be myasthenia gravis, different strokes in the brain stem. There may be also xerostomia. There may be neurological and other neurological disorders. Polymyositis as well, poliomyelitis may be the reason of dysphagia with the localization of the reason on the level of oropharynx. If we're talking about dysphagia caused by probably the body of the esophagus problems, we may say that it may be caused by achalasia, it may be caused by sclerodermia, and by diffuse spasm of the esophagus. And finally, if we are talking about the reason which is localized on the level of lower esophageal sphincter, here we can deal with dermatomyositis and of course gastroesophageal reflux or gastroesophageal reflux disease. What is regurgitation? Regurgitation is coming back of swallowed food to the oral cavity and out. As we have mentioned already, the reason is low peristalsis of the esophagus, lower or underdeveloped lower esophageal sphincter, which makes it more easy coming back of the swallowed food to the esophagus and to upper parts. Usually regurgitations are very widespread during the first year of child's life. Later on, with the improvement of the development of muscular and elastic layer and improvement by that of the peristalsis of the esophagus, with the strengthening of the lower esophageal sphincter, regurgitations go without traces. Rumination, that is a pathological sign which consists of, first of all, coming back of the swallowed food from stomach to the oral cavity. Secondary, chewing it again and swallowing it again. If we're talking about children of the first year of life, this sign is considered to be absolutely benign and normal. But usually in elder children, it is considered to be already pathological and is often associated with different sorts of psycho-emotional and even psychiatric problems. And finally, eructation in this row of symptoms. If we're talking about eructation is coming back of not a food but air, swallowed air to the oral cavity and out. And it's quite a common event among infants and even elder children. if it's not persistent, if it doesn't occur too often. So, also if it's persistent, it requires more thorough diagnostics. What are those methods of investigation we can use to make the diagnosis of some of esophageal problem? First of all, that's esophageal daily pH monitoring. We need it for detection of number of pathological refluxes. What is reflux? The word reflux means coming back of some part of food from one gastrointestinal organ to another, but it's retrograde moving. It's a movement opposite the normal direction. For example, normal direction, normally the food should go from esophagus to stomach, from stomach to duodenum. If we are talking about pathological refluxes, we mean the movement in retrograde direction, for example, from duodenum to stomach or from stomach to the esophagus. So, normally all children and all adults have physiological refluxes. They are usually very short-term and they are often related to food intake, and in general they don't change the average daily pH in lower esophagus. Sometimes if they become more often, if they are not related to food intake but may occur in between food intakes, and if they are so prolonged that generally they change average daily pH in lower esophagus, they become pathological. And due to prolonged irritation of the mucous membrane of the esophagus, there may be development of esophagitis, and hence here we have transformation from gastroesophageal reflux to gastroesophageal reflux disease. So in order to find out these pathological refluxes, esophagus daily pH monitoring is widely used. Esophageal manometry, it helps us to detect the pressure in the part of lower esophageal sphincter, and this methodic is usually additive one, is not basic, and is usually used in a specific diagnostic departments in elder children. Scintigraphy is even more rare diagnostic methodic which helps to evaluate esophagus motor activity function, or we may say motility as well. Contrast X-ray investigation. It helps us to see how even the filling in within contrast of the esophagus is, to evaluate its topography, and to find out probable congenital defects and probable problems which lie at the basis of dysphagia or odynophagia symptoms presence. And finally, endoscopy is highly accurate and very important method of diagnostics which help us to detect the structural changes of the mucous lining of the esophagus. With this method, we can't calculate the quantity of refluxes, we can't detect, we can't measure pH in lower esophagus, but we can find out either refluxes are already associated with inflammatory changes of the esophagus or they don't. Also, any problems which touch the mucous lining of the esophagus may be easily detected with endoscopy, especially if it is filled in with biopsy, with biopsy of the mucous membrane, because sometimes some problems start with the cellular level and can't be easily visualized in already an organic organ which can be detected thanks to endoscopy. For example, that is X-ray contrasting of the esophagus, and you can find out how even the contrast is spread all over the esophagus. Here we can find out strictures, that the narrowing, significant narrowing of the lower part of the esophagus with accumulation of the contrast in above part. And that is a child who is having daily pH monitoring. I would like you to see how this method is looking like. So there is a very thin and tiny tube which is inserted through the nose into the lower esophagus, and during 24 hours the quantity of refluxes, the time of these refluxes, a relationship with food intake, and average pH in the lower esophagus are calculated, are fixed and then we can make the conclusion about either refluxes are absolutely benign and physiological or they are already pathological. This is not a child, of course, but that's a picture which illustrates another point of this method, basically device, which fixes all those things I have recently mentioned. This device is fixed on the belt, and the data which we are interested in from the lower esophagus are fixed on this device during 24 hours. And these are cannules which are used for esophageal manometry, a method which fixes the pressure in the lower esophagus. Usually if it is fixed as being less than 40, so it already testifies as to that there is low tonus of the lower esophageal sphincter. And if we're talking about semiotics of esophageal damages, we always do it the same. We divide it into functional disorders and organic diseases. If we're talking about functional disorders, these are those pathologies which, with the function of just exclusively some function or several functions of some organ, in our case, esophagus, and which are not associated with organic lesions presence. So if we're talking about functional disorders of the esophagus, they are regurgitation, functional gastroesophageal reflux. So you already understand what functional gastroesophageal reflux is. That is coming back of the swallowed food from the stomach to the lower esophagus. And in contrast, organic diseases such as GERD, which is gastroesophageal reflux disease, is the presence of gastroesophageal reflux, which is already associated with the organic affection or inflammation of the lower esophagus, and if it is also associated with extraesophageal symptoms such as persistent otitis, bronchorespiratory syndrome, for example, or another extraesophageal syndromes. That is actually the picture which illustrates how everything is happening if we're talking about almost constantly opened lower esophageal sphincter, which makes it possible to permeate the swallowed food, which normally shouldn't. It normally should go only in one direction to the duodenum through pyloric sphincter, but it's moving back. In this picture, that is upper endoscopy image, and you can find out inflammatory changes of the esophagus, which is called esophagitis. That is another sort of esophagitis as well, and that is Barrett's metaplasia. In some cases, usually it happens in prolonged existence of inflammatory changes in the esophagus. A normal lining, mucous lining of the esophagus is replaced with metaplasia, it is called, with the intestinal epithelial cells. So it is called Barrett's esophageal metaplasia. It's considered to be a precancer condition. That's why it's quite important for us to timely diagnose it and to prescribe treatment. And now stomach. Stomach fundus, basically it consists of those cells which produce histamine. They are called enterochromaffin cells. Stomach corpus contains enterochromaffin cells. Again, they produce histamine. G cells, which produce gastrin. Parietal cells, which are responsible for synthesis of hydrochloric acid. Cellula principalis, which produces pepsinogen, renin, and lipase. And finally, goblet cells, which produce mucus. Pyloric part. Here we have goblet cells, which are responsible for mucus production, and D cells, which are responsible for somatostatin, one of very important factors of inhibition of acid secretion. And gastric juice composition. Hydrochloric acid, together with water and mucus and electrolytes, it presents protective factors, or protection, and they contribute to the health of the mucous lining of the stomach and protection from aggressive factors. And hydrochloric acid and enzymes, they belong to aggressive factors. Also, another aggressive factors are deficiency of prostaglandins and Helicobacter pylori and other aggressive bacteria which contribute to the affection of the mucous membrane and development of focal inflammatory forces there. Anatomic and physiological peculiarities of stomach include stomach's cardia, fundus, and his angle are underdeveloped and physiologically immature. His angle, I would like to remind you, that is a part which is created by the lower esophagus and fundus of the stomach. The elder the child is, more sharp it is. The younger the child is, more dull it is. In infants, it's dull, and that's why it enables the stomach's contents for more easy permeation into the lower esophagus. It's one of the factors of why regurgitations are so frequent among infants, no, among children of first year of life. Stomach's mucous membrane is thin, elastic, and rich in vessels. Muscular layer is underdeveloped. There are no folds in stomach's fundus. Stomach's juice low acidity is up to 2 years of age, but independently on that there is relative physiological hypoacidity. It's quite enough to fulfill all associated with its functions. Low barrier function and low enzymatic activity. Altogether, these anatomic and physiological peculiarities of the stomach create predisposition again for more easy development of different dysfunctional problems and even inflammatory process. Anatomic and physiological peculiarities of duodenum include thin mucous membrane with rich vascularization, increased permeability, and immaturity of the Brunner's glands. Again, thanks to these, no, it's not thanks, it's actually not so good when there is development of malabsorption, for example, which is characterized by violations of absorption of different nutrients, macronutrients, micronutrients. And if we're talking about symptoms and syndromes of affection of this part of the digestive system, again we are discussing pain syndrome, dyspeptic syndrome, and here we have intoxication syndrome. I would like to attract your attention, dear students, on that when you are describing pain syndrome or when you are asking your patients about pain syndrome, you should thoroughly pick up all characteristics of this pain syndrome. Why? Because sometimes on the background of thoroughly collected anamnesis about the anamnesis morbi and anamnesis vitae and thoroughly collected characteristics of pain, you can make 90 to 95% of the whole diagnosis ready. For example, if we're talking about characteristics of pain, first of all, you should find out what is the type of pain. There may be different shades of pain actually. It may be attack-like, aching. There may be Moynihan rhythm of pain. What is Moynihan rhythm of pain? That is a pain which becomes very rude, very severe as the child gets hungry, but immediately after the child is swallowing first portions of the food, this pain leaves with no traces. Usually Moynihan rhythm of pain is typical for hyperacidic conditions and especially for ulcer. When the child is hungry and his stomach is empty, the hydrochloric acid which is produced is irritating the defect of the mucous lining, causing severe pain. But as far as the child is swallowing some food, this food, like an adsorbent, it absorbs this quantity of the hydrochloric acid, neutralizes it, and then is evacuated together with this portion into the duodenum. And the pain is again restored as far as the stomach gets empty again. So that is according to the character of pain. Also, another important features you need to find out information about is relationship with food intake. There may be early pains which develop almost immediately after the child had consumed some food. It's typical for gastritis. There may be late pains which develop approximately 1 to 2 hours after food intake. There may be hunger pains, night pains, and you need to find it out. Then irradiation of pain. Irradiation means movement from one area, from epicenter of pain, to some other points of body in general, not just abdomen. Sometimes irradiation is not limited by exclusively abdominal area, no. So transferring of pain from one epicenter to another part of the body is called irradiation, and you need to find out either the pain irradiates and where exactly it irradiates. Another, duration of pain. Either it is short-term or stable, persistent, and doesn't leave even at night. Then, localization of pain. Of course, epicenter of pain gives us a lot of information, because when it is localized in right hypochondrium, first of all, we are thinking of probable biliary or hepatic pathology. When it's localized exactly in epigastric area, we are thinking of probable pathology of stomach and duodenum, and so on and so forth. Then, provoking factors, those factors on the background of which the pain usually arises. It may be taking some specific food. It may be, for example, physical loads. There may be stress, and so on and so forth. You need to find it out. And those factors which, vice versa, helps to relieve the pain. If the child tells you that he has hunger pains, which are relieved after even small portion of milk, you already can think of probable hyperacidic related disorders. If your child tells you that the pain is relieved by application of, for example, hot water bag to the epicenter of pain, or after taking antispasmodic drug like drotaverine or platifilin, you understand that the pain is caused by spasm. Like this. So many characteristics about pain, but all of them are extremely needed to collect them, to find out, because they will narrow your diagnostic spectrum, diagnostic algorithm, and will direct you exactly into investigation of those parts of the gut which are more probable to be affected in this specific case. Next syndrome is dyspeptic syndrome. And here, if we're talking about upper parts of the abdomen, of the digestive system, it includes irritation again, nausea, vomiting, and heartburn. So heartburn usually is a symptom which is caused by the coming back of stomach's contents to the lower esophagus, irritation of the mucous lining of the esophagus, which causes specific pain which is described as heartburn, because that is a burning pain with localization in retrosternal region. Sometimes the stomach's contents is not so hyperacidic, even in normal acidity, or sometimes even hyperacidity. The child may develop heartburn due to hypersensitivity of his mucous lining of his esophagus. It may be also. And intoxication syndrome. Intoxication syndrome usually consists of very non-specific symptoms. The word non-specific means that they are not specific for esophagus or for stomach or for duodenum affections. No, you can find out all the same symptoms in the case of inflammation localized in any area of the gut. Actually, intoxication syndrome is usually presented when there is inflammation present. And if you find out the presence of intoxication syndrome, signs such as headache, weakness, flabbiness, or subfebrile temperature, for example, or vertigo, or fatigue, or low appetite, you should think of probable organic lesions present. Which methods of investigation are usually used? Upper endoscopy with amine biopsy of stomach and duodenum. pH metry, which help us to assess the acid production. X-ray investigation. Nowadays, for stomach diagnostics is not widely used in childhood. Coprological investigation, or in Western countries they don't use the term coprological investigation, and then they don't use coprogram, but they use the term biochemical stool analysis, so it's up to you what you will use. Creatorrhea, it may detect creatorrhea. It may detect increased quantity of connective tissue, undigested connective tissue, cellulose, and so. When we are talking about the reason of maldigestion, what is maldigestion? That is under splitting of the substances which come from the stomach to the duodenum. And that is bad because there is no proper preparation of the nutrients to the absorption. There is no dissimilation of macromolecules to micromolecules, which enables the process of the following absorption. So for these enzymes, pancreatic enzymes and enterocytes enzymes produced by enterocytes are responsible for digestion. If everything's okay with actually pancreas and small intestines, enterocytes are absolutely healthy. But if the contents of the stomach, which is evacuated to the small intestines, is too acidic or vice versa, significantly hypoacidic, these enzymes will not be activated, and that's why it will be maldigestion and even probably malabsorption developing, and in the feces and biochemical stool investigation you will find out undigested parts of food. Feces for a hidden blood, it's called Gregerson's reaction. Sometimes there are some foci of bleeding somewhere in the gut. In order to find out them present and understand that we need to find them out because it's a very serious event. It may be even life dangerous if not diagnosed timely and treated properly. So this investigation, which is a part of biochemical stool analysis as well, is carried out. And finally, Helicobacter pylori diagnostics. Helicobacter pylori diagnostics is one of the most dangerous and one of the most known bacteria which are living in the stomach. The basic methods of diagnostic are histological investigation, when you take a biopsy, like a part of mucous lining of the stomach, and make investigation when you under the microscope find out great amount of colonies of Helicobacter pylori. This association of stomach's problem with helicobacteriosis may be considered to be proved. Another methods of diagnostics include fast or rapid urease test. That's when you take a biopsy, put it into solution, insert indicator into this solution, and according to the changing of the color of this indicator you can make the diagnosis of Helicobacter pylori proved. Another method that is urease breath test, which is based on the ability of Helicobacter pylori to split the urea and produce CO2 and ammonia ions, and you calculate them in the exhaled air, which the child exhales into a specific special sac. Then it's also stool antigen Helicobacter pylori test, when you are detecting the presence of Helicobacter pylori antigens in stool. Also, there is serological investigation when you detect immunoglobulins G and M of Helicobacter pylori in serum blood, but it's a little bit old-fashioned methodic. It's not approved as effective and accurate one for Helicobacter pylori diagnostics. This is an endoscopic tube, how it looks like. Yeah, you see that it consists of flexible tube, flexible shaft, opening for wires and instruments, eyepiece through which the investigator is looking and examining actually the mucous lining, and flexible shaft transmitting light, air, and water. And this scheme demonstrates how exactly it's looking like. This is how the urease breath test is carried out. The child, no, here we have a beautiful woman, lady, is given juice or some fluid with the added urea. The patient should drink this urea, and after that the investigator is collecting the air into a specific container, and analyzer calculates how many ammonia and CO2 ions appear in this air. If it's too much of them, it means that there is some bacteria which splits urea down. Usually that is Helicobacter pylori. And now semiotics of stomach and duodenum damages. Again, we have the group of functional violations, and here we have functional dyspepsia and organic diseases like gastritis, stomach, and duodenal ulcer. If we were talking about functional dyspepsia, usually two basic functions violation lie at the basis of its development. First of all, that is stomach acidity production function if it's too intensive, and especially if it is combined with the hypersensitivity of the mucous membrane of stomach. We can say about epigastric pain syndrome, which is one of types of functional dyspepsia. The child feels pain. If motility of the stomach is violated, the stomach becomes too flabby, lazy, and doesn't want to properly contract. And it influences, of course, evacuation. And the child starts experiences postprandial fullness, early satiation, hardness, discomfort in epigastric area, especially after foods. We are thinking of postprandial distress syndrome, which is another type of functional dyspepsia. But in all these conditions, there are no still organic lesions of the mucous membrane of the stomach. And if there is already inflammation present, we are calling this already with the ending itis, which in Latin testifies to inflammation. Gastritis, stomach and duodenal ulcer are already organic lesions. If we're talking about gastritis, it's more superficial. If we're talking about ulcer, it's more deep lesion, which may even cause spread to other organs, which is called penetration, or which may be transmural and be complicated with so-called perforation. In elder individuals, it may be may be transformed into malignization, and also it may be complicated with bleeding. So actually, bleeding of ulcer is one of the most widespread complications of ulcers in childhood. Anatomic and physiological peculiarities of small intestines include mucous membrane, which is thin with increased permeability, Peyer's platelets barrier function is decreased, Bowhen's valve is weak, and increased length of frills is detected. Intestinal juice contains epithelium cells, enzymes, leukocytes, mucus, and taking note 22 hormones, how important this part of the gut is, right? If it produces 22 hormones with differently directed actions, among which the most important are secretin, cholecystokinin, and motilin. Large intestines APP. It contains thin mucous layer, rich vascularization of it, increased permeability, and increased motility. Ascendant colon is characterized by the absence of hostration and presence of flexures. Descendant colon is characterized by long frills in sigmoid colon and underdeveloped muscular layer with weak fixation of rectum's mucous membrane and submucous layer. And here we are talking about intestines damages semiotics. Again, we have already known pain, dyspeptic, and intoxication syndromes. If we are talking about pain syndrome, so again we need to characterize it: epicenter of pain, irradiation, provoking factors, factors which help to relieve the pain. Either it's persistent, or we can say periodicity and character, type, relationship with food intake, sometimes relationship with some certain food intake. It's, for example, may be helpful for lactose intolerance diagnostics, for celiac disease diagnostics, and different types of gastrointestinal allergies in general. Dyspeptic syndrome, here we are talking about meteorism, bloating, tenesmus, diarrhea, constipation, hemocolitis, the presence of mucus and pus in feces. When we are talking about meteorism, that's overaccumulation of the gas inside the intestinal loops with its intestinal too intensive moving throughout the intestinal loops and coming out from the intestines outside. Tenesmus, these are frequent and painful urges for defecation. Diarrhea, these are defecations which are more often, usually more than 4 times per day, with the contents, the fecal content, which is more fluid than it should be watery. Constipation is either delay of evacuation of the feces, or more problematic defecation, active defecation, complicated by evacuation of more solid, more problematic feces, which causes discomfort, pressure in the child, and typical posture of the child. This is the posture in which the child tries to keep him from the defecation, tries not to defecate in order not to experience this discomfort and pain again. Hemocolitis is discharge of the blood present in the feces, and the presence of mucus and pus in feces is obligatory, is essential mark of inflammatory process present inside the colon. Intoxication, again, you can find out non-specific signs which are present always for intoxication of any origin. Methods of investigation include clinical blood analysis. It's not specific, it may help us to understand either there is inflammation present or it's not, but it won't for sure show us in which part of the body this inflammation is present. Coprogram, again biochemical stool analysis, may help us to detect undigested substances, creaturia, amyluria, steatorrhea, iodonophil flora, which testifies to the inflammatory process in the intestines, much mucus, increased quantity of leukocytes, erythrocytes. Estimation of carbohydrates in feces, bacteriological investigation of feces with usually, if we're talking about cultural analysis, usually it's also associated with estimation of the sensitivity of the bacterial flora to different antimicrobial agents. Also, fecal calprotectin is very important biochemical marker which help us to understand either we deal with functional disorder or there is already inflammation present in the intestines, and it's assessed in the feces. Lactose respiratory test or lactose intolerance hydrogen breathon test. That is complete name of this investigation. That is, if we want to know either the child is tolerant to lactose, we need to carry out this method of investigation. The child is given to drink a lactose-containing solution, and after that the quantity of hydrogen ions are calculated in the exhaled air. If their quantity is too significant, it means that lactose is not normally digested in the intestines, and it's used by microflora, which splitting it down produces a lot of hydrogen ions which are absorbed and through the bloodstream comes to lungs and are appearing in the finally exhaled air, with the child exhales to a special tube through mask if this infant, or just in a routine usual pathway if the child is elder. Immunological investigation, for example, increased contents of different antibodies specific for celiac disease. These are tissue transglutaminase antibody, endemesial antibodies, disseminated gliadin peptides antibodies, and so on and so forth. They are specific for celiac disease and they are very helpful to detect it. Biochemical blood analysis. Colonoscopy with intestinal mucous membrane biopsy. It's very important when, for example, it's difficult to differentiate between different inflammatory bowel diseases, so biopsy will help us to do it. Rectoromanoscopy, X-ray investigation, which is called for intestines irrigoscopy, and genetic finally consultation, genetic testing. For example, the same celiac disease may be finally verified with the presence of DQ2, DQ8, HLA antigens in the analysis. And that is a capsule which is used for video capsule investigation. The principle of this method is that the child is swallowing this capsule, it's moving throughout the whole gut and then removed with feces from the rectum. And when it's moving through the gut, it shows us on the monitor the pattern of different parts of the mucous lining of the gut. That is actually the own method which we have for investigation of small intestines. As far as the small intestines is very long, we can't reach it with neither upper endoscope nor with colonoscope, and that's why it's very difficult to visualize the processes which are happening there with mucous lining of the small intestines. That's why video capsule endoscopy helps us to do that. That is actually how the methodic of colonoscopy looking like. That is absolutely healthy colon, and that is a colon with polyp. If we're talking about semiotics of intestinal diseases, again, functional disorders. Usually it includes functional diarrhea, functional constipation, irritable bowel syndrome. Inflammatory bowel diseases among the most widespread, which you may face in your practice. There are Crohn's disease, which affects actually the whole gut, not just colon, and ulcerative colitis, which predominantly affects the colon, and in 5% of patients it also may occupy terminal ileum. Primary malabsorption, it includes disaccharidase insufficiency, monosaccharidase insufficiency, celiac disease we have here, exudative enteropathy. And finally, secondary malabsorption, which may be caused by, for example, cystic fibrosis. For today, that is all on our topic. I wish you good luck, good day, and very successful study. Goodbye.